I'm Mathew Harrison. I am a medical psychotherapist and liaison psychiatrist here in Leeds, and I'm the local PI for Fresh Start here. So I try and help Fresh Start happen on the ground. So I'm going to talk to you a bit about sort of the practicalities and what actually happens. So we'll start with the team, and the main team in which Fresh Start runs here in Leeds is our acute liaison psychiatry service. So that is a service primarily staffed by nurses, though there are some allied health professionals as well, and they see all people who present to the general hospital with self-harm, be they A&E or the wards. And that team is not only the team that provides all of our recruitment and recruits all of the patients for us, but provides the majority of our interventionists, so the people who are trained to deliver the psychological therapy. And I think that's important to bear in mind, because as we go and talk about the work later, and these are individuals who usually have had no experience of delivering psychological therapy before, and the work of an ALPS practitioner is actually quite radically different to the work of a therapist doing ongoing therapy. We have also the other A team we have available to us is our research team, who help us with the recruitment and help follow these patients up, which leads us on to recruitment. Hopefully it's not like trawling, but sometimes it does feel like you need to get everybody in the net. The way practically recruitment is working is that our ALPS practitioners, our liaison practitioners, are asked to screen everybody who they assess with self-harm. And if the person has self-harm more than 4 times or more, then to consent them to contact for Fresh Start. We don't ask our ALPS practitioners to think about the suitability of the patient. That is done by our colleagues in the R&D department when they then contact the patient to consent them for research in the contact. What was I going to say about recruitment? Now, recruitment is a challenge, and I think recruitment is probably the biggest challenge that we face right now. I think that's for a variety of reasons. We have had the pandemic effect, and as Nav was alluding to, self-harm presentations decreased, but also we saw people with more severe self-harm who may not be appropriate for studies for various reasons. And also we had issues with members of the team being redeployed and our team in chaos and sort of trying to set up a study in that team. There's also, I guess, the challenge of embedding research in a team which is transient by its nature, that these practitioners are shift workers. Just getting all the members of the team in a room together can be a challenge at times. We are getting there, but it sort of requires sort of thought and adaptation to sort of think about how we can do recruitment the best. I guess the other aspect of the challenge of recruitment is the patient group, and without sort of making sweeping generalisations, we've heard about attachment, and these are often patients who may have difficulties with attachment or may have felt excluded by other services. So now engaging them in a study can be challenging, and even if they say yes at the point of their assessment in A&E, getting them through to the point where they're ready to receive the therapy is a difficult process, which is helped by our R&D department. Presuming we recruited people, the next bit is the work, and this is the bit that's really interesting for me, I guess, as a psychotherapist, that the participants receive weekly therapy, and in Leeds we are delivering both psychodynamic interpersonal therapy and CBT with one of the practitioners, most of whom are ALPS practitioners. We've had a really, really supportive manager of our ALPS team, who I need to sort of thank, Donna Hansen, who's released her staff for their training, releases her staff for their weekly sessions with the patient, and releases them for admin time and the things that they need to be able to see their patient. We'll hear what some of the interventionists have said on the next slide. But I think if you think about the normal work of an ALPS practitioner, which is gathering facts and assessing the likelihood of further self-harm, and perhaps only meeting that patient once in their lifetime, asking them to move to a position of seeing a patient at a regular time every week, to move towards understanding the meaning of self-harm and the meaning of an interpersonal relationship, is a sea change and offers them a completely different perspective on the work that they might ordinarily be doing in the A&E department, which I think challenges them, but they feedback really sort of enriches their work anyway, because they feel that they're sort of tooled up to use this in their day-to-day work too, and then they get a contrast between seeing a patient regularly and also doing their sort of crisis assessments, which they'd ordinarily do. And you know, and they get training, sort of formalised training, but also the weekly supervision with a psychotherapist, either in Leeds a psychodynamic psychotherapist, that's myself, or a cognitive behavioural psychotherapist, where they learn, you know, even just some of the common factor stuff about psychotherapy, like having the same room, you know, having a set time, those things that sort of seem second nature to us in psychotherapy, but aren't normally part of an A&E, world. And you know, this is what they say actually. So this is, some people in the room may recognise their quotes, but these are sort of feedback that we had from the feasibility arm of the study from some of our interventionists. And you know, they talk about it being a great balance between the crisis assessments that they're doing and then doing this other piece of work, that they can use it in other areas of their work. And indeed, the amount of keenness amongst interventionists has been great. We're sort of over-recruited for interventionists. We've got everybody in the A&E team saying, can I do this? Can we do a bit more? Can I do some of this training? Which I think really just shows an appetite on the ground for clinical teams for, you know, being involved in research and doing things. So, where are we up to next? So, as Elle says, we are hoping to be able to open SafePit alongside Fresh Start. We've recruited all the interventionists we need for SafePit here in Leeds. We have ongoing challenges with recruitment, which we're hoping to tackle, and that will help us sort of set up SafePit alongside that. And you know, hopefully we can run those two things on together. We have sort of new members of staff coming through ALPS, and so we've sort of got ongoing training for those guys, ongoing supervision for those guys. I just remembered something I was going to say, but I won't. But I will say here, but it was part of the previous slide, and that is sort of risk supervision. I mean, interestingly, with this patient group, we haven't had huge issues with risk. I think that is an interesting, given that we're dealing with a patient group who use self-harm multiply. Therapists get sort of external risk supervision as part of the training, and I think that's interesting that on the ground that's not been a big issue, even though that might be a worry when you see this research study of thinking, gosh, how are we going to manage the risks around this, and that's why these patients may have been excluded. I think actually in practice we've not found it to be a particular issue at all, which is interesting. So that's part of my whistle-stop tour, and I'll stop there.